Psych with Mike and Brett is now a book. Psych with Mike and Brett, A User's Guide to Being Human, is our new book that's available at Kendall Hunt, Barnes & Noble, and on Amazon. Pick up a copy today and leave a review. Also, find us on YouTube and subscribe to the podcast. That really helps us out. Now, it's time for Psych with Mike and Brett.
Welcome into the Psych with Mike and Brett library. I can't talk again. I am Dr. Michael
That's
Mahan.
a good thing. Is it depressing?
It can be.
Yeah. And I'm Brett Newcomb. And today we're going to talk about, as clinicians, what do you need to know and how do you need to implement it in terms of treating people that are suffering from depression, and how do you determine how the level of severity for the depression?
Right.
Is it what we call clinical depression, or is it just depression? I'm in a bummed out mood. I've been having a bad couple of days. I had to buy 2 new tires. I don't have a lot of money. Woe is me, life sucks. Or is it depression to the point that I can't get out of bed, I can't take a shower, I can't brush my teeth, I have no contact with anybody, and I'm thinking about suicide?
Mm-hmm.
I mean, there are degrees of severity that as a clinician you need to be aware of.
Absolutely.
To determine the level of interventions that you make.
And when we were talking about this before we went on air, you made a great distinction, which is that you really have to make a differential diagnosis. So we just published a book. It is on Amazon. It's on the Kendall Hunt website, which is our publisher, and it's on Barnes & Noble, called Psych with Mike and Brett, A User's Guide to Being Human. And while we didn't specifically cover depression itself, we did talk a lot about anger and anxiety. And when you're looking at depression, one of the things that is super important to do is to make that differential diagnosis, because those things have a lot of overlap.
Do you want to explain what a differential diagnosis is and what it's used for?
So a differential diagnosis means that you are looking at the entire constellation of issues or problems that a person is dealing with, and you're trying to come to the most correct diagnosis that you possibly can. Because you could look at depression and anxiety and the symptoms of those things, and there's a lot of overlap. And so if you're looking at a person and you diagnose them as being depressed, but what they really are is anxious, then the treatment modality that you employ may not be as effective as it could be at helping them get symptom relief.
Or
So
as a clinician, you need to be aware that oftentimes these diagnostic categories are comorbid, and one of them will, in appearance, supersede the other. And so if I have someone that's severely clinically depressed that comes in, I need to be aware that underneath that depression may be anxiety.
That's right.
And so as the depression alleviates from the treatment, what often happens is the anxiety manifests, and then you're going in a different direction whether you know it or not, because the presenting behaviors and issues overlap frequently. Right. So when we talk about diagnosing, we're basically talking about using the Diagnostic and Statistical Manual of the American Psychiatric Association, which gives categories and labels, but under each category label it says, okay, in order to be diagnosed with this, they have to have 5 of these things and 3 of these things and 2 of these things in this time window. And quite often in cluster symptoms, those symptoms manifest 5 and 3 and 2 across 2 or 3 categories.
Right.
So the appropriate diagnostic labeling process involves an assessment of each category to see, okay, at least for today's snapshot is we're dealing with clinical depression. Next week, we may be dealing with anxiety. Next week, we may be dealing with something else.
Right, right. So when you meet a client for the first time and you're thinking about that differential diagnosis, what are the things that you see that lead you to think in terms of depression?
Well, when I see them for the first time, I'm looking at the nonverbals before they've ever even said anything. Are they clean? Have they shaved? Have they apparently brushed their teeth? Do they smell bad? Is their hair unkempt? Do they make eye contact? Are their eyes light? Are they sparkling? Are they energized as they talk? Are they flat? Is the face affect-free? Is it just hanging there with no expression on it? Is it mobile? What does their body language say? As you shake their hand as you bring them into the office and have them sit down. How do they move? How do they sit? When they are seated in your room and you begin to have a conversation with them, how freely do they engage? How alive and energized do they appear to be? I mean, what you're doing is making rolling assumptions. As I bring you into the room, I'm already starting to pre-clarify and quantify, what do I think I'm looking at? What's going on with this person? Could this be an alcohol or drug-related issue? Or is this some kind of family issue? Or what's going on with this person? And then I ask them. And as they start to try to respond to me, I get more cues about how sharply they're connecting with me and understand what I'm saying, and how they are responsive, if they can come up with coherent sentences, or if I just get shrugs. And very often they will say, well, I don't know why I'm here. My wife made me come. My boss made me come. My mother made me come. I hate her. And then you say, well, say more about that. Say more about that. And sometimes they can't or won't yet, because they don't know you. They're not open to you, and they're often not open to coming to therapy initially. So you have to go through the process.
And you had mentioned a word earlier called comorbid.
Yeah.
And that just means that two things happen at the same time. And I really am glad that you threw out the whole alcohol thing, because the use of some kind of drug, whether it's alcohol or marijuana or cigarettes, as a way of self-medicating is frequently an aspect of depression. People who are depressed are looking for ways to feel less depressed, and they will oftentimes use those kinds of, absolutely.
And sometimes people self-medicate with risky behaviors. I was laughing because I remember 35 years ago when I first went into practice, therapists that I did collegial supervision with were having vehement articles about whether or not it was appropriate to allow a client, especially one suffering from depression, to smoke in session. And if lighting a cigarette is a way to distract yourself from a feeling that you need to be in touch with in order to make progress in dealing with it. So I don't know about that anymore, because so many buildings that we work in now say we're smoke free, but also because the profession has moved away from the idea of allowing smoking at all, with the exception of hospitalized schizophrenics. And in mental hospitals, if you are in a mental ward or unit, you are often allowed to smoke in designated areas.
I was just going to say, but it's designated areas now, because if you collect money from a federal source, which all hospitals do, you can't get that money if people are smoking in the building. The one accommodation that they made was, yes, on those locked facilities, which I worked on for a long, long time. And so we would have designated smoking areas, and you would have people in there who would be dragging their oxygen tank around, and they would take their oxygen mask off and smoke a cigarette and then put their oxygen. I would go in there and take the cigarette from them, and they'd be like, you can't take. I'm like, look, if you want to blow yourself up, that's your business, but you can't blow me up.
My wife's uncle was dying, was in a hospital and dying, and within the last 2 weeks of his death, they were still rolling his hospital bed outside the hospital to the designated smoking area so that he could smoke. Because at that point, what are you going to do? Except that he couldn't do it in his room, and he couldn't do it inside the building, and somebody had to physically take him in and out. But they would do that because it granted him some relief from the awareness that he was dying and the things that he was feeling.
And we're not making necessarily a judgment on whether or not
we're talking
these
about
things are good or
clinical
bad. We're just talking
judgment.
about
in terms of precisely and correctly identifying what are we dealing with here. Because then you have to figure out, okay, if I think this is what I'm dealing with, how do I approach it? How do I help this person deal with it? How do I help them get better? And dealing with chronic depression, one of the things you need to be sensitive to as a professional is it's not like seeing somebody with a broken leg who's hobbling around on crutches. It's not like seeing somebody's surgery scar because they just had surgery. After a while, the affect limitations of being with this person who's non-responsive in terms of giving you any kind of energy feedback gets to a place where you're like, screw it. This is a waste of time. I don't want to do this. Where you resent them because they aren't moving. That's a clinical issue that you need to deal with in your own right, because you have to be available for the client and responsive to the client. but the energies it creates in you, you have to deal with somewhere else, which is why you need supervision. Why I recommend you don't ever really work in an office alone. You need somebody down the hall that you can go to after a session and say, oh my gosh, help me understand what just happened, or help me, I don't like this person, what's going on here, whatever it might be. Because you need a venting valve for those kind of feelings that build up inside you as a clinician.
So when we are dealing with individuals who are depressed, they've come in, we've made an initial assessment, and we've given them a diagnosis. We believe that they are depressed. The ways in which we treat that are?
Stabilize, make an assessment about, maybe make a medical referral for potential medication, because I don't do that. I never have done that. I'm not qualified to do that. But it's something that I recognize I need to do for the sake of the client, sometimes to have an assessment made by a physician. So that's a factor.
Or a psychiatrist.
Who's also a physician and able to prescribe. So, and in some states, psychologists are also able to prescribe lower level medicines, not category 1. Then try to get them engaged in micro movement. Can we make a list of 5 things, even seemingly stupid things, like brush your teeth? Did you brush your teeth today? Did you take a shower? Did you do 3 push-ups? Could you do? What would be a sign of your own control over your destiny? Let's begin to try to teach you that even though there's huge resistance, there are things that you can do that you have control over that can be accomplishments. And their response is going to be, that's really stupid. I'm paying you this kind of money to tell me to brush my teeth.
I was just going to say that.
And I'm saying, that's exactly what's going on here, because what I know is that if you brush your teeth every day for a week, you're going to feel a level of accomplishment and ownership. And you may deny that right now, but if you're truly suffering the way that I think you're suffering, this is a weapon that you have control over, that you can have control over, that can begin to chip away at this oppressive control of the depressive ideology.
And they will say, I've had this experience many times, where you say, hey, just get out of bed and take a shower. And they'll say, well, that's stupid. I'm supposed to take a shower anyway. Well, I would never want us to get into a shouldistic argument, like you should do these things. But B, then this should be easy for you. If this is something you believe you are want to do anyway, then just do it. Just go ahead and do it, and let's see what impact it has.
And also, there's a secondary payoff. A shower feels good, and if something feels good, you can't feel bad and good at the same time.
Right.
And so, even if we can get a window of 5 minutes in a shower where you can park the overwhelming burden of depression away from you, that will tell your brain at some level, I can fight this. I have a tool. I feel a little bit better.
And one thing that I do with people who are depressed, and I'll ask you if you like this or if you've ever done this, I will say to people, how much of the day do you think that you are depressed? And they'll tell me 24 hours. And I'll say, well, I know that's not true. They'll say, well, how can you know that? Because I think I'm depressed 24 hours a day. I'll say, well, part of the day you're asleep. Whether you're sleeping more or sleeping less, part of the day you're asleep. You can't be depressed while you're asleep. So that's at least that much time that you're not depressed. And even when you are awake, there are lots of times during the day when you are not actively depressed that you may not be aware of. And what I would like to do is to try and track that more consistently, more clinically. Can you keep a record for me of the times when you recognized that maybe you weren't depressed, like maybe you smiled when you were watching a TV show or looking at something on the internet, and if you recognize that, can you make a note of that? Because I want people to start to become aware of what it feels like to be depressed, but also what it feels like to not be depressed.
Another thing as a clinician that you need to be aware of, especially around the issues of food and sleep, is that someone who's seriously depressed can have issues with either one. And so if I'm really depressed, sometimes I eat to make myself feel better. I don't necessarily eat healthy. I eat things that make me feel better. And so I eat more sugar. And if I'm depressed at that level, I may sleep all the time or may not be able to sleep at all.
Mm-hmm.
I may not be able to eat at all or eat all the time. So just asking the question, you have problems with food consumption, you have problems with sleep, is it giving you the information that you need as a clinician to make a proper assessment of how to make an intervention and how to help? And then the methodology or the messaging begins to be, in order to help, we need to teach you that you either do have or can have control over these behaviors. And we learn those just like any other learning. We learn it in small, measurable increments. And so if you have a list of 5 tasks that you can do today, and you've done them 3 out of 7 days this week, then next week we want to try for 4 days, and the next week for 5 days. And each day the clinician needs to remember to say, or each week when they come in, how many days were you successful with all 5 tasks? Not as a way to say, well, you're really a loser, you failed, you couldn't do it, but as a way to say, this is progress. It's hard. We recognize that it's hard, but you've moved this much this week.
Right.
Let's hold on to that and move just incrementally more next week and encourage them. But it's got to be honest feedback and honest encouragement. If you're blowing smoke at them, you're doing damage to them. If you don't believe it, if you don't think it's helpful, it's not helpful.
Absolutely.
2 other things that I want to talk about is one of the points that often occurs, especially in comorbid diagnostic categories, is what we call a flight into sickness. As soon as they make enough progress that it feels like change is afoot, they will often regress right at a critical juncture. You begin to talk about, well, I think we're almost done here. Let's phase out over the next 3 visits. And the next 3 visits, they're going to have a crisis and they're going to regress. And so you need to be aware of that. You need to anticipate that. You may even need to foreshadow that with them and say, how are we going to understand that when it happens? Because again, if you're going to do damaging behaviors as a way to stay sick, we want to know that so we can identify and say, well, we were expecting this. Now see, it's here. Now how are we going to block that? How we take that card out of the deck. So whatever you got left, let's play with those cards. And it's a challenge.
Right. So you don't want to reward that flight into sickness by then saying, okay, well, let's work harder and longer.
And shame them and guilt them. You want to say, okay, that was an expected event. How severe was it? How bad is it? And can we address it directly, or do we need to just park it for a while and keep working on what we're working on?
Because if you don't identify it, then what may happen is that may become the pattern where the individual gets better. Then it starts to feel like, oh, we're wrapping up. Now I'm sick again.
Yeah, dating. If I've been dating inappropriate characters and I've decided, oh, gosh, appropriate characters that I'm supposed to be looking at, I don't like them. I don't want them. And you have that conversation with them about, we need to change your channel, your internal channel for what you're looking for. And they'll say back, I don't like those people. I'm not attracted to them. I'm attracted to ruffians and losers and alkies and druggies. Yeah, you are, but that's dysfunctional and it's causing you problems. So you need to either not date at all for a while, or make yourself go into new environments and go out with somebody you aren't attracted to.
Right. So I call that an attractometer.
Yeah.
And I have this conversation with people all the time. I say, if you're looking at your altimeter in an airplane and it's broken, you're going to die because you're going to crash your airplane.
Right.
If you're looking at your attractometer as the basis for whether or not you should be in a relationship, that's going to be bad. So what you have to do is find somebody that checks all the boxes for the best relationship that you can imagine, but that you may not necessarily be attracted to, and at least hang around that person for a while, if not date them. And I cannot tell you how many times...
the resistance is horrible.
The resistance is horrible. Yeah. But when they finally give in and do that, they end up in long-term relationships, if not...
Well, and then there's always a kiss of death. You know, I'm dating you and I say, I really love you, but as a brother. I love you as a friend. I need you as a friend, not as a lover, because you don't attract me that way. I'm not attracted to you sexually, but gosh, I really want you to be my friend. And when you have a woman or a man tell you that, then you need to know, this is not going where I want it to go.
Right. Yeah.
So that's depression, and that's depressing, and hope we haven't depressed you.
So, again, we have a book out. We would love for you to go to the Kendall Hunt website or Amazon or Barnes & Noble and pick up a copy. If you have any questions for us, you can get us at psychwithmike.com, or you can go on michaelmahan.org and send us a question. You can leave a comment on the website or on the YouTube site. We would love for you to go and find us on YouTube if you don't regularly get us that way, and subscribe to the show, because that really helps us out. And as always, if it's Friday, it's Psych with Mike and Brett.
Also, if you go, do the search on Amazon or Barnes & Noble, Psych and Mike with Brett, and that will pull up the book title for you.
Yeah. Okay. Have a great rest of your Friday.